Malaria diagnosis, we have clinical diagnosis, which isn't easy. Fever suggests malaria, but of course it also suggests many other diagnoses. Gene-sustained blood smears have been around for more than 100 years, and we now have rapid diagnostic tests. So this is a not very good photograph, actually, of a thin smear showing a huge number of rings of P. falciparum. This is from the laboratory. You are more familiar with thick smears, which are a very efficient way of making a diagnosis, but the thin smear is better for a good look at the parasites. And it's not that difficult with the help of a cheat sheet such as this one to distinguish the different parasites. Plasmodium falciparum is the parasite that classically has ring forms, and more than one ring in one red cell is highly suggestive of Plasmodium falciparum. You do not see the more mature forms of Plasmodium falciparum circulating. That's because they are, as I've mentioned, binding to blood vessels. But with the other parasites, you do see the more mature forms. Also, you may see some gametocytes, the sexual forms, and the gametocytes of P. falciparum, these banana-shaped things, are quite different than the gametocytes of the other species. So that's blood smears. We've been using them for a very long time. They work well, though of course they need a fairly experienced microscopist. However, in much of rural Africa, microscopy has not been routinely available. And so until 2010 in Uganda, and I'm quite sure this was the same in Cameroon, the recommendation was any patient with fever or history of fever within the last 24 hours without evidence of other diseases should be treated for malaria, even with a negative blood smear. So you should do a blood smear. If it's positive, you treat for malaria. And if it's negative, you treat for malaria. That was the recommendation until 2010. Finally, the WHO in 2010 said, we can do better than that. We should diagnose malaria. And then if it's not malaria, we need to figure out what it is and treat the patient accordingly. And so the new recommendation is prompt parasitological confirmation by microscopy or another method, if at all possible. It's not always possible. There are still clinics that are not capable of diagnosis, but that is the goal now. The standard of care is the goal. Treatment solely on the basis of clinical suspicion should be considered only when you cannot make a parasitological diagnosis. And the important new diagnostic tests, as you know, are rapid diagnostic tests for malaria. Primarily, these are immune tests. They're like ELISA tests, but in a little card that allow you to recognize certain antigens of the parasite. The one that's most common in Africa is HRP2, which is an antigen only of Plasmodium falciparum, not the other malaria parasites. But again, that's acceptable in Africa since the vast majority of malaria infections are P. falciparum. HRP2 is a protein that's very abundant, so it's a good protein to look for. It's highly sensitive. There are simple assays available from many different manufacturers. However, there are a few limitations. Because there's so much HRP2 around, it will stick around in your bloodstream even for a few weeks after the malaria is better. So if someone was recently treated for malaria and they're perfectly fine, they may still have a positive test. Some parasites do not express HRP2. This is another recent research area, probably more true in South America, but there's also evidence from Africa now that there are some P. falciparum parasites that don't make HRP2. So that's very scary. Your RDT will miss these people, leading up, of course, to a misdiagnosis, and the child could do very badly. HRP2 will not recognize non-falciparum infections. We do have other antigen tests that recognize the other parasites. Quality control has not been ideal. There are many different manufacturers. I worry a bit about what tests are out there. But overall, RDTs have become very popular because they obviously are easier to do than microscopy, and they have approximately the same sensitivity and specificity as microscopy. We have much more sensitive tests, of course, like PCR, but these are not practical in a field setting. And also, we're not sure we even want such a sensitive test, since if we look hard enough in some parts of Africa, everyone will have very low-level parasitemia. the level of sensitivity of a blood smear or an RDT is probably about what we want for routine diagnosis of malaria.